Hello, everyone, and welcome to McGill Cares webcast series supporting family and informal caregivers. I'm Claire Webster, a former caregiver, certified dementia care consultant, and founder of McGill University's Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee the program, who include Dr. José Moret from the Division of Geriatric Medicine and Dr. Serge Gauthier, Professor Emeritus, formerly of the McGill University Research Center for Studies in Aging. These webcasts are made possible thanks to the generosity of our donors, and I would like to thank the Zeller Family Foundation for sponsoring today's webcast. So today we will be talking about understanding Parkinson's disease and Lewy body dementia. My guest is Dr. Madeleine Sharp. Dr. Sharp is a neurologist specializing in movement disorders. Her research goal is to develop more precise models of cognitive dysfunction in patients grounded in neurobiology to develop and test new behavioral and pharmacological therapies. Dr. Sharp, welcome to McGill Cares.
Thank you so much for having me.
So today we're going to allow you to give us a presentation on really understanding Parkinson's disease and Lewy body dementia. So I'll let you take it away.
Thank you so much, Claire, for that introduction. And I'm really thrilled to be able to be here and contribute to your wonderful talk series. And so, yes, you asked me to speak today about the dementia that occurs in association with Parkinson's disease, as well as Lewy body dementia. And so the title of my presentation is Lewy body dementias, which is a bit different than dementia with Lewy bodies. And already I'm bringing up all of this confusing terminology. And so I hope to be able to clear that up a little bit. So Lewy body dementias is actually an umbrella term that refers to two different conditions. One is Parkinson's disease dementia. And so that's the dementia that occurs in people who have Parkinson's disease. And the second is dementia with Lewy bodies, which is dementia that occurs in people who don't necessarily already have a diagnosis of Parkinson's disease. So this umbrella term Lewy body dementia simply refers to people who develop a dementia, and so who develop cognitive problems, and who are presumed or proven eventually, if we go to autopsy, to have something in the brain called Lewy bodies. And so Lewy bodies are inclusions in neurons, and you can see this image here, this dark brown staining refers to this abnormal protein that we refer to as alpha-synuclein that accumulates inside neurons in inclusions that are referred to as Lewy bodies, named after the person who initiated discovery. And so as you've probably had speakers previously in this talk series talk about different forms of dementia, most of the neurodegenerative disorders that we deal with are associated with different types of abnormal protein accumulations in the brain. And so in this case, we're specifically talking about these particular protein accumulations called Lewy bodies. And Lewy bodies can occur in the setting of Parkinson's disease, and they can occur in the setting of dementia with Lewy bodies. And in fact, the only difference between these two, we'll call them subconditions, is the progression over time and in what order things appear. But at the level of the brain, when pathologists go in and look at the brain, the appearance of the brain is actually quite similar. And so there's still actually a lot of debate as to whether these are two truly different conditions reflecting somewhat different disease mechanisms, or if they just happen to be the same disease that for whatever reason we're catching at different points in time. So to give you a bit more of a visual about all of that, in Parkinson's disease, so this is a picture of a brain, kind of a side view of the brain. And you can see these regions in red, which refer to the parts of the brain that are typically affected in the earlier parts of the disease. And as a result of this part of the brain being affected, people with Parkinson's disease will initially manifest with the motor symptoms that are generally well recognized. So tremor, slowness of movement, changes to gait. And over time, and that can be over a period of anywhere between 1 and 20 or even more than 20 years, the disease and the parts of the brain that are affected spread to include most of the brain eventually. And in particular, these regions, I hope that you can see my mouse. as I drag it over the screen. In particular, this kind of outside part of the brain, which we refer to as the cortex. And that's important because in order to have a dementia, the part of the brain that is affected needs to be the part of the brain that regulates cognition. So things like attention, memory, visual processing, those sorts of things. And so in order for someone to manifest with dementia, we know that the parts of the brain that must be involved are these kind of more outer parts, so the cortical regions. And so in Parkinson's disease, there's this slow progression with initially these deeper parts of the brain that regulate the motor function being affected. And eventually, in the majority of people, there is a spreading of this disease process to involve these outer parts of the brain, which are the cortical regions, which results in dementia. Now, in dementia with Lewy bodies, when people present and when they manifest with their signs of dementia, they already have involvement of these outer regions of the brain. But that is not to say that they never had involvement of these deeper regions. As I was mentioning earlier, in autopsy studies that have compared the appearance of the brains of people who were diagnosed with dementia with Lewy bodies and people who were diagnosed with Parkinson's disease, in fact, there's similar involvement of all of the brain regions. So why is it that these people don't initially present with the motor symptoms? We don't exactly know. Maybe the degenerative process happens in all brain regions at once rather than following this slow progression through the brain regions. That's still unclear. So that's the kind of general organization of how we think of the dementias in relationship to Lewy bodies. So either Parkinson's disease dementia or dementia with Lewy bodies. So one of the questions I was asked to talk about is how is it that we make this diagnosis? And so I wrote here in italics, clinical diagnosis, because in the neurologist's office or in the internist's office or the family doctor's office, we can only talk about clinical diagnoses. And that's important because the highest level of certainty that we can have in making a diagnosis of a dementia in someone who we're seeing in our clinic is actually of a probable diagnosis. A definitive diagnosis can only be made at the time of autopsy because there's only so much, of course, that we're able to ascertain from what's going on in the brain when we're simply examining someone in the office, and even as a result of doing different kinds of brain scans. And so this may have come up in prior talks, but I'm putting it up again here, the clinical definition of dementia. And so, and this applies to whether we're talking about dementia with Lewy bodies, Parkinson's disease dementia, Alzheimer's dementia, frontotemporal dementia. Dementia is really a descriptive term that refers to the degree to which someone's cognition has changed and how much it's affecting their function. And so to be diagnosed with dementia, one has to have had a progressive cognitive decline of sufficient magnitude to interfere with social or occupational function. And you can see already there that this is a very subjective assessment, and that the point at which one would be considered to have dementia is greatly influenced by all kinds of other factors that have nothing to do directly with the disease process in their brain. And so you might not notice that someone has a reduction in their social or occupational function if they have wonderful supports around them, because it's less apparent that that function is reduced. People who are or that the reduction in social or occupational function might also be more apparent in someone who is still working or someone who is still very actively involved in their everyday life. And so any change from what they were doing may be more apparent than someone who's a bit older and perhaps a bit less involved in a variety of different activities. So what are the features that allow us to make these different diagnoses? So we mentioned Parkinson's disease dementia. I more or less said this already, but the diagnosis of dementia of Parkinson's disease dementia can only be made in someone who already has an established diagnosis of Parkinson's disease, and so who has the typical motor findings of that disease, and in whom the cognitive decline has occurred progressively over a matter of many years and sometimes up to decades. And just to give you a bit of context, after a variety of epidemiological studies have shown that after 10 years of disease with Parkinson's disease, about 75% of patients would be considered to have dementia. But what's interesting is that we probably in general in the movement disorder clinic, where we are following people with Parkinson's disease for 5, 10, 20 years, we often don't use the term dementia. It's kind of viewed more as the natural progression of the disease. And that label, I think, is less often applied to people than in other settings, like people who actually have fairly mild cognitive changes who go to a memory clinic and who are more quickly diagnosed with a dementia. So the second diagnosis that we've been talking about is dementia with Lewy bodies. And here, as a clinician, as a neurologist trying to make this diagnosis, because when we're considering a dementia with Lewy bodies, that means we're considering a diagnosis of dementia in someone who doesn't already have Parkinson's disease. And that means when we're evaluating someone with new cognitive changes and cognitive impairment, we're having to consider the other diagnoses and the other dementias that could possibly explain these cognitive changes. So the things that we're considering are the other two most common dementias, and those are Alzheimer's disease or vascular dementia. And so vascular, I'm sure that your audience is familiar with Alzheimer's disease, and for vascular dementia, it's the dementia associated with having had multiple small strokes. And so the key features of dementia with Lewy bodies are the aspects of the cognitive change that allow us to make the diagnosis of dementia with Lewy bodies over one of Alzheimer's disease or vascular dementia are first, that there's some hints of some motor symptoms that are similar to those of Parkinson's disease. And the second two items, the third and the last item on this list, are hallucinations and fluctuating cognition. So these are two changes in cognition and behavior that are very particular to dementia with Lewy bodies, even or maybe especially in the earlier parts of the dementia. And so I'll go into a bit more details later about what these two symptoms represent. But really, the thing that we're doing as a neurologist when we're trying to make a diagnosis of the type of dementia that someone may have is that we're observing the pattern of cognitive and behavioral changes. So we're trying to take the whole picture of the person and trying to see in what areas of their cognitive and their behavioral function are they having trouble, and can that give us clues about which parts of the brain are primarily affected by this dementia. And that's important because Alzheimer's disease typically tends to affect different parts of the brain than dementia with Lewy bodies, and that can give different patterns of cognitive deficits and of cognitive changes. So about that pattern of cognitive changes, the way we think about that is we think about the different domains of cognitive function. So this is a somewhat descriptive way of thinking about all of the different cognitive functions that the brain supports. And the big categories that we tend to think about when we're trying to assess people's cognition along all of the full range of cognitive functions is, how are they doing with respect to their attention? How are they doing with respect to their executive function, their visuospatial function, and their memory? And so I'm going to go through each of these and not in too much detail, but just to give some examples of how it is that we assess for changes in those domains and the kinds of tests that people are often asked to do in the clinic to get at that. So attention is probably somewhat intuitive to people what this means. The way that this comes up when people are describing the changes that they have felt themselves or that others around them, that their caregivers and their loved ones have noticed, is things like difficulty following conversations or difficulty following the flow of a story, watching a TV show and kind of losing track of what was happening early on. Now, of course, there's a lot of overlap between these different cognitive domains, and problems with memory, for instance, could also influence your ability to keep track of a storyline when you're watching a movie or something like that. But these are the typical types of things that people who have changes to their ability to pay attention to things will describe, or that others will notice of them. And so some of the tests that we do in the clinic, so some of these examples that I'm going to give are drawn from the MoCA, the Montreal Cognitive Test, which may have been brought up at previous sessions, or that people in the audience may have seen administered or had administered to them. And so one of the tests that we do in this MoCA is we ask people to repeat a series of number in the same order. So for instance, 2, 1, 8, 5, 4. And so, of course, you need memory, but more than memory, you actually need to be able to pay attention to the examiner as they are telling you this list of numbers. And you have to be able to really concentrate on what they're saying and block out everything else that is happening in the room around you in order to be able to actually then remember them and speak those numbers back. The other typical test that we'll do that is also a test of attention is we'll ask people to count back in sevens. So to start at 100 and to count to subtract 7 and to keep subtracting 7. And so that too is a test of attention. I mean, it's a test of math. And so it is true that people differ very much in their math ability, and that has nothing to do with cognitive impairment. But in the absence of, known difficulties with math, you have to be able to pay attention to the number that you just said, to keep in mind the instruction that you were given, which is to count back in sevens, and to focus on that mental calculation, and then to keep doing that and do that over and over again. So it's actually fairly high demand on attention. So the next domain that I wanted to mention is executive function. And so this is basically, the skills that are required if you're the CEO of a company. You need to have very good executive functions if you're the one who's in charge of anything. And all of us have that kind of role in our own lives. And so it's those types of things, but at the scale of everyday life that can be affected when you have changes to your executive function. So the questions we'll ask people to see if they have trouble with executive functions are things like, have you noticed trouble with planning? So planning things like trips, making lots of decisions, having to plan the meals for a week. And it's a little hard to put your finger on what is the thing that can make it hard. So of course, if you have very poor attention skills, it'll be hard for you to kind of sit and actually plan an entire trip at the computer or plan your week of meals. But it's more than just attention. It's the ability to be able to integrate multiple sources of information and to stay on task. The other thing that can be involved in executive functions is the ability to multitask. And so we hear about this difficulty, especially in people who are still working. And most of us who are still in working positions, I mean, multitasking is important at all stages of life. But, when you're working and you're being bombarded by emails and phone calls and all that kind of thing, the ability to quickly change tasks and to remember what it is that you're doing when you get to the next task reflects the ability to multitask. And so in the kind of everyday at home life, one way this may come up is the inability to, for instance, continue cooking while holding a conversation, or to drive while being on the phone. And so that's why we'll recommend to people who are starting to show some cognitive impairment, even if they're still in good shape to drive, that they should not be driving while they're doing anything else, because that requires multitasking. And then also a little bit more hard to describe is that all of the skills that are required in solving a problem are also considered executive function. And so some of the ways in which we assess this in our testing, one is called the word fluency task. And so in that task, we give people a minute and we ask them to name all of the words they can think of that start with the letter F, or all of the words that they think of that belong to a particular category, like farm animals. And while this is also a test of language skills, which generally we're less worried about in people who have Parkinson's disease, dementia, or bodies, it actually reflects a lot of executive function. Because if you try and do this in your head now, you're going to have a system to your approach. Either you're going to scan the room that you're in and look for all of the things that start with F, or start in a category and then go through all of those words that you think can start with F. And there's going to be a logical sequence to the words that you come up with that reflect some degree as executive function. And if you lose executive functions, it becomes harder to do that. And therefore you're slower in being able to pull up these words. And so the number of words that you can generate is reduced. And then there are some somewhat fancier problem-solving games that we tend to not be able to do just in the clinic, but that are done if you go for full testing with a neuropsychologist. So the third domain of cognitive function I wanted to talk about that can be affected in the Lewy body dementias is visuospatial function. And so one of the ways that this comes up is people describe a tendency to get lost, or even kind of earlier hints of that can be slightly more difficulty orienting oneself in unfamiliar territory. Or sometimes we'll ask, if you go to a new mall, you tend to get turned around more than you used to. Is it a little destabilizing for you to go to a new place like that? That would reflect a change in visuospatial function. Difficulty assembling things, drawing things. I mean, some of these things are things that people are less prone to doing in their everyday life. And so sometimes the challenge is finding examples that are applicable to the person's life to really try and get a sense of whether this is something that has changed for them. And so here too, we have a couple of tests that we can do in the clinic setting to start to assess for this. One is whether your ability in drawing a clock. And the second is copying a cube. So I have some examples here. So you see here on the left is an example of a cube. It's often on the piece of paper normally that we use for this test. We show an example of a cube that has been drawn in 3 dimensions like this. And then we ask people not even to draw from memory, but to copy the picture of the cube. And that is something that can become very difficult. And again, there's always individual differences in drawing skills. And so some of these things are things that we have to consider. But you can see here that this particular person had a lot of difficulty drawing this cube and kind of lost the ability to make it a 3-dimensional shape. And so the corners are off and some of the lines don't connect. And so we actually have a specific way in which we grade the change in ability to draw a cube. And to show you an example of drawing a clock, so I think this actually, I'm sorry for the quality of the image. What you can see here is that the circle was drawn. And so the exact instructions given to people are, please draw a clock and include all the numbers. And then you let the person do that. And then you tell them, please draw in a particular time. So often the time that we use is 10 past 11 or something like that. And we make sure that they draw the shorthand and the longer hand. And what you can see here is this person drew the outside, the outline of the clock. And then the numbers are kind of bunched in the bottom here and are not evenly distributed around the full circumference of the chalk. So that too reflects a change in the ability to kind of organize items in space for an item that is very familiar to most people. And so the final cognitive domain that I wanted to talk to you about is memory. And so people often think about memory as being a classic change in cognition associated with Alzheimer's disease. And that's true. It's also a change that we see in most dementias, but in other dementias, the cause of the memory deficit or the memory impairment is different when we think about it in terms of the processes that are going on in the brain. And so maybe I'll get to that in a second. I'll just give you first the examples, the ways in which we will ascertain for the changes in memory is we'll ask people if they have a new tendency to be forgetful. So are they misplacing objects, forgetting appointments, going into rooms and not remembering what they were going in there for? And of course, all of us experience some degree of this. And so as with all other domains, I think, everyone is so much more in tune with the changes in their memory function because it's something that's so classically described with dementia. So everyone has a tendency, I think, to scan themselves for changes in their memory. The trick is always to determine, is this similar to what you see in terms of changes in the people around you who are of similar age, or does this stand out as being a bit more than that? And is this worrisome to you and to the people around you? And so the key thing about the memory changes in Parkinson's disease dementia and in dementia with Lewy bodies is that unlike in Alzheimer's disease, the problem here is simply with accessing the memory. So the memory may be made. So that means that the information is actually encoded into the brain, but getting access to that information, which we call the process of retrieving information, retrieving memories, is what is difficult. And we actually think that's because the ability to retrieve information depends a lot on executive function, because you have to be able to organize in this setting for this demand. This is in the information that I need. This is where it's stored, and it is connected to this other information. All of those things need to come together very quickly to be able to access the information at the speed at which we are used to accessing it in our everyday use of memory. So the problem is not with making the memories. Whereas, for instance, in the more classic form of Alzheimer's disease, the problem is really with making that memory in the first place. It's not there. And so we can begin to tease apart those different types of memory problems with some of the tests that we do in the clinic. So the classic way in which we assess this is we give people a list of 5 words. We tell them to practice them with us, and then we give them a few minutes. We go on to do some other stuff. And then we ask them which or how many, we ask them what words they remember of that list of 5 words. And so what we'll see, the pattern that we'll see in people with Parkinson's disease dementia or dementia with Lewy bodies, is that they may have difficulty remembering some or all of those 5 words, But if we then go on to give them a clue, either saying, so let's say one of the words you were asked to remember was table. And so they don't remember table. And then we give them a clue like a piece of furniture. That clue is all that they needed to actually be able to go and retrieve that information. And that is kind of the evidence to us as clinicians that memory was encoded. It's just that retrieving it was a bit difficult. And so the next level of hint or clue that we'll give people if the category clue is not sufficient to help them is we'll give them a choice. So a multiple choice of different words. So table, chair, and desk, and see if they can remember the item when presented with a list of items that includes the one that they were asked to remember. Whereas, for instance, classically, someone with Alzheimer's disease and associated memory problems, even with with those clues, they will not be able to remember the item because the encoding it, the actual storage of it in the first place is where the problem lies. So those are the domains of cognitive function that are affected. But and this statement applies to all dementias. There are many other spheres of function that are affected too. I'm focusing today just on cognition and on behavior. I mean, there are other things that are that we spend a lot of time discussing with people who have, in particular, dementia with Lewy bodies and Parkinson's disease dementia. But there are also a lot of behavior changes in these diseases, and in a way, it's kind of it's a funny distinction to talk about cognitive changes and behavioral changes because there's a lot of relationships between the two. And after all, they all relate to changes in brain structure as a result of disease and changes in neurotransmitters and therefore signaling between brain regions. But we tend to, call some changes cognitive changes and some changes behavioral changes. So I'm going to go through briefly some of the main behavioral symptoms that we spend some time assessing and also counseling on in people with Lewy body dementias. So the first is apathy. And the simplest way to think about apathy is that it's a loss of motivation. And often what it is that people will note is that they just need a bit of an extra push to do things. It's not that they don't enjoy things. And so it's not that they have anhedonia or a loss of enjoyment of participation in activities. It's just that it's harder to get themselves to do it. And this is actually an area of great interest in my own research group, where we and many, many others around the world are trying to understand what exactly this represents. And it's a really important symptom, not only because it's present across most dementias, but because it can really affect the quality of life, both for the patient as well as for the caregiver, because a lot of things can become more difficult if the apathy becomes quite severe. The second is mood symptoms. So mood symptoms are very common in the dementia with Lewy bodies. In fact, we think that a lot of people develop mood symptoms before they develop signs of either Parkinson's disease or dementia with Lewy bodies, and anxiety and depression are among the most common. Hallucinations, as I mentioned initially, is actually one of the core features of dementia with Lewy bodies and of Parkinson's disease dementia. And hallucinations can occur in Alzheimer's disease too, but typically much later. And so when they occur early along the kind of timeline of cognitive changes, that's another clue that we're dealing with one of the Lewy body dementias. And so there's also kind of a temporal evolution to these hallucinations. Initially, people will often describe just that they have a sense of a presence, and then they feel that they see a shadow passing them by, and when they turn, they don't see anything there. And so these are not the types of things that people tend to report. You really have to ask them about them because they don't tend to stand out to people as being particularly abnormal. And over time, generally, these very subtle illusions and sometimes hallucinations can develop into more elaborate visions, so full hallucinations, and we refer to those as complex hallucinations. And so people tend to see little children are often prominent in hallucinations of people with Lewy body dementias, little animals, bugs kind of crawling along the bottom of the wall. And most of these hallucinations are typically visual, and so there's not an auditory component to them or a smell component, but occasionally, especially later on in the disease, those elements can be included too. And then finally, kind of related to behavior and cognition is sleepiness. And I should have written here too, sleepiness and fluctuations in attention. And so one of the features of both Parkinson's disease dementia and dementia with Lewy bodies is that people tend to will often describe, or their caregivers will describe, that they have good times of the day and bad times of the day, and that their cognitive function is quite different in those good times compared to those bad periods of the day. And those fluctuations can happen over the course of hours. And so in those, times where they're not doing so well, it's either because they're drowsy and they're feeling a little sleepy, or just because their level of attention is just much reduced compared to what they are able to achieve at other times of the day. And this too can be quite concerning. And so the final piece is I just wanted to touch briefly on treatment. And I'm not going to go into any details here, but I'm happy to answer any questions, of course. And so the strategy or the approach to treatment is first that we want to address all of the symptoms of this person who's presenting with cognitive changes. And that includes the cognitive symptoms and the variety of them, the behavioral symptoms, as well as all of the other symptoms that can be associated with some of these dementias. And so sometimes that can have to do with blood pressure changes, changes to smell, constipation. And so I can answer questions about those too. They're not cognitive symptoms, but they are directly related to the dementia as well. And then once we have a good sense of what all these symptoms are, it's important to figure out with the patient and with their caregiver what the most bothersome symptoms are, because it can be difficult to manage everything, not to mention because the medications can have side effects. And so we often have to prioritize the things that are most important. And in a single clinic visit, it's also important that we generally only want to make one medication change. And so there's often a process of figuring out, well, what's the thing that we want to address now? What's most bothersome, or what's most interfering with the ability to care for this person? And that's what we focus on. And related to that point, the key is to try to achieve a balance between the benefits of some of the medications and some of the approaches and the side effects and the difficulties that can arise. And so the different general parts of our approach to management are one, education. I think I'd be really curious to hear feedback from your audience, but my sense that I get from talking to families is it can be very helpful to go through all of these different aspects of the way that dementia can affect a person's cognition and behavior, because it can often validate all of the difficulties that one is having at home and situate them clearly in the setting of the disease. And that's not, especially for things like apathy in particular, and mood symptoms too, people don't often realize that they're directly related to the dementia, and it can create a lot of frustration. And so to recognize that these things are key symptoms of the dementia, I think can sometimes help. But the other piece of education is also to set realistic expectations about what it is possible for us to do with non-pharmacologic strategies and with pharmacologic strategies, and to give a sense of what is the general timeline that we're looking at. How do we expect things to change over time, without, of course, ever being able to give specifics, which can be difficult, but nonetheless to give a sense of what's to come. And so we have non-pharmacologic approaches, which, for us in our movement disorders clinic at McGill, we're really fortunate. We have a multidisciplinary care team. And so we have an occupational therapist, social worker, nutritionist, 2 nurses working with us. And so the whole team is important in putting in place all of the strategies that can help. And then we have a variety of pharmacologic approaches. I think that I will stop there because I know that Claire may have some questions.
Dr. Sharp, thank you very, very much for this very, very informative presentation. I mean, I found it very helpful, especially to take us through the whole clinical assessment, how you do it. That's something that we don't get to see too often. So first of all, with regards to education, I mean, unfortunately, since there is no cure for dementia, I mean, it's really about becoming as educated as possible. I would really like to let our audience know, for those people who may have not received the latest newsletter, that the McGill Dementia Education Program has recently published a free resource for all family members that can be accessed at mcgill.ca/dementia. It's called Dementia, Your Companion Guide. And it talks a lot about how to manage some of the challenging behaviors, a lot of non-pharmacological approaches, and really provides a really great explanation for all the different types of dementia. I have time for one question, Dr. Sharp. In terms of the use of medications, it's really about managing the behavioral symptoms, right? It's really about managing anxiety, managing depression, or managing those hallucinations.
Yes. Those are probably more so than the cognitive changes themselves, in a way, the areas where we have best success, I would say, with pharmacologic strategies. And really, we have a variety of drugs that we can use. Some of them have been developed specifically in the context of Parkinson's disease. So those would be the ones that change the levels of dopamine in the brain, which we know to be reduced in people with these conditions. And then others are medications that have been borrowed from the world of Alzheimer's disease or from the world of psychiatry. And fundamentally, what's happening in the brain is there's a change in the neurotransmitters, because the neurons that are dying as a result of the disease process are neurons that normally would produce neurotransmitters like serotonin, which is linked to depression, noradrenaline, which is also in some ways linked to depression and linked to attention, acetylcholine linked to Alzheimer's disease and the cognitive changes that we know of that sphere, and then the dopamine, which we know is linked to some of the symptoms in Parkinson's disease. And so all the medications we have are to kind of tweak those neurotransmitters and affect them directly. And that's kind of how we hope to achieve some improvements in the different symptoms.
Well, Dr. Sharp, thank you so much for being with us today on McGill Cares. And once again, it was a really very, very educational and informational presentation. So thank you very much.
Thank you so much. Happy to be here.
This webcast is an initiative of the McGill Dementia Education Program, which is funded by private donations. Once again, I would like to thank the Zeller Family Foundation for supporting today's webcast. If you would like to make a contribution to our program, or for more information, including having access to the Dementia Your Companion Guide, please visit us at mcgill.ca/dementia. And if you would like to join our mailing list to be notified about upcoming episodes of McGill Cares and other programs that we have within our department, please email us at dementia@mcgill.ca. Thank you for watching.